Welcome back to Decode Healthcare with Harshal. We are officially on part 44 of our 100-part ICD-10-CM guideline series, and today we are stepping right into Chapter 8, which covers diseases of the ear and mastoid process. Now, if you've ever felt the sting of a rejected claim for an ear procedure, well, you are definitely in the right place. Our mission today is to completely master Section IC8. We're going to conquer the otitis media combination rules, environmental tobacco exposure stacking, and those absolutely strict laterality laws for hearing loss. Let's get into it. So let's start with a massive audit danger. Why do claims for routine things like tympanostomy tubes or hearing evaluations get rejected so frequently by payers? I mean, you've got the operative report, you know for a fact the procedure happened, but the claim scrubber still kicks it back with a giant red alert. Well, the answer almost always lies in how we translate the patient's anatomy and the specific circumstances of their ear condition into our ICD-10-CM codes. Here's our game plan for today. We'll start with the laterality audit danger, do a quick anatomical breakdown of Chapter 8, cover the otitis media tobacco mandate, dive into inner ear and hearing loss, and wrap up with how to avoid those unspecified codes. All right, kicking things off with Section 1, the laterality audit danger. This is hands down the biggest financial pitfall in ear coding, and it all comes down to failing to specify exactly which side of the body you're dealing with. According to the CMS ICD-10-CM official guidelines for coding and reporting, specifically Section IB13, ear conditions strictly require laterality. The guidelines explicitly warn us that codes for the unspecified side should rarely, if ever, be used. If the side isn't documented, you are officially in a danger zone. You can't just guess, and you definitely shouldn't take the easy way out with an unspecified code. If the medical record is conflicting or missing that crucial detail, you have to query the provider for clarification. To put this into perspective, the final character in the ICD-10-CM structure dictates this exact side. A 1 indicates the right ear, a 2 indicates the left ear, and a 3 indicates bilateral when the condition actually affects both ears. But that final option, a 9 means unspecified ear. Submitting a claim that ends in a 9 practically invites an automated claim scrubber to just reject your bill outright. Payers know that physicians always document the side they operate on, so an unspecified code instantly signals incomplete coding. Moving right along to Section 2, Chapter 8, Anatomical Breakdown. To truly understand how these codes are organized and why laterality is so deeply embedded in them, we need to ground ourselves in the anatomy. Chapter 8 maps out the auditory system perfectly, moving from the outside in. We start with the external ear from age 60 to age 62, covering things like swimmer's ear or impacted cerumen. Moving a bit inward, we hit the middle ear and mastoid from age 65 to age 75. This area houses the eustachian tubes and the ossicles, and it includes conditions like otitis media and mastoiditis. Deeper still is the inner ear, age 80 to age 83, where the cochlea and vestibular nerve live, which gives us codes for Meniere's disease. Then we have other disorders, like hearing loss, from age 90 to age 94. Finally, intraoperative and post-procedural complications live in age 95. Let's dive deeper into Section 3, otitis media and the tobacco mandate. Zooming in on that middle ear section for otitis media, there is a highly specific coding law you absolutely have to master. When you're coding acute or chronic otitis media from categories age 65 to age 67, you first have to clearly distinguish between non-suppurative and suppurative. Non-suppurative just means the inflammation involves a clear, pale fluid accumulation. Suppurative, on the other hand, means there's an active infection with a purulent, pus-like discharge. You really have to read the documentation carefully to determine this clinical difference so you can select the correct code category, but honestly, that's only the first step. Here's an incredibly important, yet often missed, mandatory instruction found directly in the tabular list. Under these middle ear infection categories, there's a strict rule. If a patient has an ear infection, you must check the documentation for tobacco exposure. If a child's ear infection is linked to passive smoke at home, the tabular note explicitly states you have to use an additional code to identify exposure to environmental tobacco smoke. So, let's see how this builds into a fully compliant claim through mandatory code stacking. First, you code the primary otitis media condition, making sure to remember your right, left, or bilateral digits. Next, you check for any underlying diseases that might need to be coded first, like a viral infection that's actually causing the otitis. Finally, you securely snap that secondary code right underneath the primary one. You literally must report environmental tobacco smoke exposure with Z77.22. Or if the patient is a smoker themselves, use the appropriate tobacco use or dependence code from category F17. Missing this secondary code means you're just flat out ignoring a direct tabular instruction. Okay, on to section 4, inner ear and hearing loss. As we travel even deeper into the anatomy, we hit the intricate complexities of hearing loss. Coding in category H90 requires us to understand exactly what type of loss is occurring. Sensory neural deafness means there's actual damage to the hair cells in the cochlea or the vestibular nerve itself. This is vastly different from conductive hearing loss, where a sound wave is physically blocked in the external canal or the middle ear. Sometimes you'll even see mixed hearing loss, which is exactly what it sounds like, a combination of both. Also, keep in mind that sensory neural loss is often coded as a late effect or residual of a previous condition like meningitis. Now, when coding inner ear conditions, whether it's the inherited bone growth of otosclerosis in H80, the severe vestibular disruptions of Meniere's disease in H81, or specific hearing loss in category H90, laterality remains an absolute necessity. But category H90 takes it a step further. It actually forces you to look at the contralateral ear, meaning the opposite ear. You have to specify if the patient has unilateral hearing loss with normal hearing in the contralateral ear, or if they have unilateral hearing loss with restricted hearing in that contralateral ear. The code maps directly to this specific relationship, so you have to comb through the audiogram or physical exam documentation to capture the exact status of both ears. And speaking of both ears, the CMS official guidelines have a fantastic logic puzzle for coding bilateral conditions during separate encounters. Let's say a patient has a bilateral condition, but the surgeon is only treating the right side today. You still assign the bilateral code because technically the condition exists on both sides at the time of the encounter. However, if they come back for encounter 2 to treat the left side and the right side was completely resolved during the first surgery, you now assign the unilateral left code. But if that first surgery didn't completely resolve the right side, you stick with the bilateral code. It's a tricky rule, but absolutely crucial to get right. Finally, Section 5, avoiding unspecified codes. Let's wrap this up with the ultimate takeaway for Chapter 8. If you remember one single thing from this explainer, make it the golden rule of ear coding. Never let a claims scrubber reject your tympanostomy tube placement or your hearing aid evaluation just because you took the easy way out with an unspecified code. That final digit 9 is a massive, unnecessary financial risk. The anatomical side is almost always explicitly documented in the physical exam or the operative report. Dig for it. And if it's genuinely missing, query your provider. So, I'll leave you with this final, provocative thought. If just one simple final digit can cost a practice thousands in rejected ear claims, what do you think happens when we start dealing with the complexities of the human heart? Make sure you hit that like button, subscribe, and share this explainer with your coding networks, because in Part 45, we are moving straight into Chapter 9 to conquer hypertension, secondary hypertension, and causal relationships. You won't want to miss it. I'll see you there.